In this next segment, we're now going to trace the nerve as it continues down the upper extremity, look at the motor and sensory branches that come off it and when they come off, the muscles they innervate and their function, motor and sensory deficits as a result of impingement of the nerve as it goes down the upper extremity, and signs and symptoms of radial nerve pathology. So the radial nerve is going to start descending the arm in the posterior wall of the axilla. And that is the first place it can be compressed and injured. For example, using crutches that are not fitted properly, where it comes all the way up into the axilla and exerts pressure for prolonged periods of time, having your arm hanging over a chair into the axilla and fall out of sleep. Those are at least two examples of how you can compress the radial nerve. And the symptoms are going to be everything distal. Now in the axilla, the posterior cutaneous nerve of the arm comes off, so it may be spared. About all the other sensory and motor functions that we discussed potentially could be involved and could be abnormal with this high radial nerve lesion. From there, it's going to travel down the medial arm, posterior medial, to the axillary artery, and then it's going to travel through a triangular interval formed between the teres major, the long triceps, and the humerus. Small little triangle interval that it's going to go through to enter the posterior arm. Then it's going to descend down the posterior arm between the long and the medial heads of the triceps, innervating both muscles. And then from there, it's going to continue going down the arm, and about the mid-arm, mid-humerus level, it's going to go through what's called a spiral groove or a radial groove. So it's going to kind of travel obliquely in an inferior lateral direction through that groove, along with the deep brachial artery. It's tightly bound in that groove, so if you have a mid-humerus fracture, it potentially could injure the arm in that area. Now, as it's traveling down the posterior arm and starting to travel through the groove, two motor branches and two cutaneous branches come off. So as it's traveling through the groove here, it is going to slip down to the anconeus, and just adjacent to it, the groove separates the medial and the lateral origin of the tricep heads. It innervates the lateral tricep. So two cutaneous branches that come off as it's going down the posterior arm are the posterior cutaneous nerve to the forearm, or posterior antebrachial cutaneous nerve to innervate the skin of the posterior forearm, and the inferior lateral cutaneous nerve of the arm. So again, it's going to come around through the spiral groove and send a cutaneous branch over here, and also it's going to send one down here, and as it's coming around here, it's going to hit the lateral triceps and also down here to the anconeus. So those are four branches, two motor and two cutaneous. If you have an injury, a mid-humeral injury in the spiral groove where it stretches the nerve in the groove and injures it, it may or may not affect those two cutaneous and two motor branches we just talked about. So you still could have elbow function, even if it does affect the lateral triceps. You still have the long and the medial head have already been innervated, so you still could have, might have some weakness, but you still have some elbow function. But what you don't have is all 12 muscles in the posterior forearm potentially could be affected. So all the actions we just went over, they could be weak with a humeral fracture. Now, a common sign for this is called wrist drop. So you have the patient's arm like this, you hold their hand up, and then you tell them to hold that hand in that position when you let it go. As you let go, the wrist drops. So that's a positive sign for a high radial nerve injury, even in the axilla or in the arm, such as the mid-humerus. Then the radial nerve is going to continue around the radial groove, and it's going to go through the lateral intermuscular septum to enter the anterior compartment of the arm. And from there, it's going to travel down the lateral cubital fossa, right in this area here. And it's going to, right adjacent to it, of course, is the brachioradialis that travels between the brachioradialis and the deep portion of the brachialis. So it could innervate oftentimes does innervate the deep portion of the brachialis, and it also will send a slip to the brachioradialis and the muscle adjacent to it, which is the extensor carpi radialis longus. So it innervates those muscles as when it enters the anterior compartment and travels in the lateral cubital fossa at about the level of the elbow or just distal. Once it goes a few centimeters distal in the lateral cubital fossa over the radiocapitellar joint, that's where it's going to split into a superficial branch and a deep branch. The superficial branch is sensory only, so let's look at it first. It's going to travel deep to the brachioradialis, which is right here, and then about 8 or 9 centimeters down, it's going to emerge between that muscle and the muscle next to it, which is the extensor carpi radialis longus. And because it's emerging between those two, it can kind of get scissored as you do excessive repetitive supination and pronation, and you could have pain in that area known as Wartenberg's syndrome. So that's a potential injury site of that sensory nerve. Then from there, it's going to continue down, go over the anatomic snuff box, over the extensor carpi radialis, or extensor pollicis longus rather. So it travels over there right into the dorsal web space that you see right here. Okay, so it's going to emerge like this between the brachioradialis and the extensor carpi radialis longus, down through the anatomic snuff box into the dorsal web space to innervate, as well as the lateral 3½ fingers right here up to the middle phalanx. Okay, so lateral 3½ fingers and hand. That's the destination of the superficial branch. And with an injury, you could have, again, pins and needles, abnormal numbness, tingling, more in the dorsal web space and to a lesser extent in the fingers as well. So that's the superficial. Then we have the deep branch. The deep branch is a C7, C8 motor nerve. So all the muscles it innervates from here on out is going to carry C7 and C8 nerve fibers. The deep branch is going to wrap around the head of the radius, so radial head fractures could potentially injure it as it's in the lateral cubital fossa in this area here. And then from there, it's going to enter the two heads of the supinator. And this is a potential impingement site. As it goes, the superficial head actually forms a fibrous arch called the arcade of Froesch. And it can be impinged there, or it can be impinged as it starts going through the two heads of the supinator, especially with repetitive overuse of continuous supination and pronation, construction workers working all day long using tools, screwdrivers and such, that could potentially impinge the nerve. Now this nerve, this deep branch, is oftentimes referred to as the posterior interosseous, because as it passes through the two heads of the supinator, it's going to continue down the posterior interosseous membrane. So it's oftentimes referred to as the posterior interosseous nerve, but it's the same nerve. It's just a direct continuation of the deep branch. So this posterior interosseous nerve, as it's going through the two heads, if it is impinged between the two heads of the supinator, it's known as posterior interosseous syndrome or radial tunnel syndrome if it's compressed between those two heads. The only muscles that haven't been innervated at this point that are going to be infected with posterior interosseous syndrome of the deep branch or the posterior interosseous branch being impinged between the two heads of the supinator are, and this is how you can kind of remember it, they're going to be the 3 superficial muscles on the medial side and the 4 most distal deep muscles. So there's 7 muscles that remain to be innervated as the deep branch, or posterior interosseous nerve as it's called, passes through the supinator and travels down the posterior interosseous membrane between the superficial and the deep posterior muscles. So let's look at those. What are the medial 3 superficial muscles? Are the extensor digitorum. So that can cause weakness in finger extension. Then over from there, it's the extensor digiti minimi, again, weakness in finger extension of the little finger. And then the most medial is the extensor carpi ulnaris. So you could have weakness in extension and ulnar deviation. So those are some signs of motor weakness with posterior interosseous syndrome from the 3 medial superficial muscles. And the remaining 4 muscles, because there's 7 muscles total that the posterior interosseous nerve is going to innervate, are the most distal deep muscles. So those are going to be the 3 muscles that form the anatomic snuff box down here. So that's going to be your abductor pollicis longus, your extensor pollicis brevis, and then up here your extensor pollicis longus. So that, of course, results in thumb extension and abduction weakness, potentially. That could be affected. We call that a sign that you can look for is the hitchhike sign. So the ability to hitchhike, to extend the thumb like this, is diminished with an injury, posterior interosseous nerve injury, or anything higher nerve injury for that matter. And of course, the ability to extend the fingers. That's another sign from the extensor digitorum, and then the extensor digiti minimi and the extensor indicis as well. The extensor indicis is the final deep muscle that is affected by posterior interosseous syndrome potentially. So again, posterior interosseous syndrome, radial tunnel syndrome as it's called. Some of the things you might see there are the hitchhiker sign, inability to extend the thumb, inability to extend the fingers as I'm doing here, and possibly weakness with wrist extension and ulnar deviation, especially when done simultaneously. So that is a summary of the structure, function, and pathology of the radial nerve.